wanted to ask you first about this study into the performance of a novel genetic risk score to identify risk of VTE in patients with cardiometabolic disease. Can you take me through that study and sort of the usefulness of this novel genetic risk score?
Absolutely. It's a great question, a terrific study, of course. The issue that's come up is how can we really best risk stratify patients, figure out who's at high risk and who isn't. And the reason that's important is if we know who's at high risk, we can target preventive therapies to them in terms of lifestyle modification and potentially escalate medical therapy or target medical therapy. That's most relevant when one is talking about medical therapies that are more expensive branded medicines. It's also relevant when one is talking about medicines like antithrombotics where there's a bleeding risk. So it is a way potentially of targeting therapies to patients most likely to benefit, least likely to be harmed, where things will be most cost effective. So that's the basic premise behind polygenic risk scores and why we need more than just current risk calculators for a variety of different disease states. We're talking about VTE here, but the same principles would apply for secondary prevention or other areas where polygenic risk scores are being introduced, certainly in terms of research, and in some cases, people have been pushing for clinical incorporation. It's been controversial, polygenic risk scores. It's not been clear how much they really add in a variety of different situations, but in this particular analysis, this was an examination to see what the ability might be in terms of VTE prediction. So quite novel in that regard. And certainly it did appear there was incremental value in terms of identifying different genotypes and the amount of risk they confer in this particular setting, as has been done in other settings, such as I alluded to earlier, secondary prevention, for example. I think, the predictive ability is modest and one needs to acknowledge that fact, but I think it serves as a great platform for future research. There's a lot we don't know about VT and why some people have recurrences, others don't, who should be on lifelong antithrombotics, who should be on a shorter duration. Should you keep the intensity of the antithrombotic high throughout the entire duration? Should you sort of de-escalate? All of these are questions that are really important ones, and potentially the ability to more precisely risk stratify, including with use of polygenic risk scores, might be useful, but much more research, I think, is needed in this area.